Welcome to Doctors on Call. I'm Becky Kaiser. Among women, breast cancer is the second most common cancer diagnosed after skin cancer and the second leading cause of cancer deaths after lung cancer. On average, 1 in 8 women will develop breast cancer in their lifetimes. About 2/3 of women with breast cancer are 55 or older, and most of the rest are between 35 and 54. Fortunately, breast cancer is very treatable if spotted early. Localized cancer can usually be treated before it spreads. Cancer of the prostate is the second most common cancerous tumor worldwide and is the 5th leading cause of cancer-related mortality among men. Almost all cases are diagnosed after age 65, and more than 80% of men develop prostate cancer by age 80. Breast and prostate cancer, our topic tonight on Doctors on Call with our guest, Dr. Perez-Tamayo of the Central Care Cancer Center.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from CAMCO, the state's only Kansas-based medical liability provider, serving medical professionals and advocating for the health for all Kansans.
Russell Regional Hospital, experts, neighbors, friends.
Your family is our family. Staff at Smith County Memorial Hospital wants to set the standard of excellence for healthcare in North Central Kansas.
Breast and prostate cancer, our topic tonight on Doctors on Call with our guest, Dr. Perez-Tamayo of Central Care Cancer Center. Dr. Perez-Tamayo is an MD, of course, FACR and FACR, a radiation oncologist and president of Central Care Cancer Center. Dr. Perez-Tamayo completed her radiation oncology residency at the Medical College of Wisconsin. She was awarded prestigious fellowships to both the American College of Radiology and the American College of Radiation Oncology for her contributions and service through education, research, and service activities in the practice of radiation oncology. Her academic appointments include the University of Michigan, the University of Kansas Medical Center. She's participated with the American College of Radiology Commission on Small and Rural Practices, was appointed to the President's Cancer Council, and is part of the Kansas Comprehensive Cancer Control Panel. Dr. Perez-Tamayo is board certified by the American Board of Radiology and the American Board of Internal Medicine subspecialty of hospice and palliative medicine. She has expertise in brain and body stereotactic procedures along with high dose rate HDR brachytherapy. Dr. Perez-Tamayo sees patients at Central Care's Great Bend, Emporia, and Kansas City locations, as well as at Heartland Cancer Center in Garden City, a provider with Central Care Cancer Center. The information that you're bringing to you on Doctors on Call may be useful when you see your own physician. So while we start waiting for the first calls to come in, we want to come directly to Dr. Perez-Tamayo. And just before we got started, you were telling me that you wanted to make sure people understand you have a lot of letters behind your name, a lot of titles. What do those mean exactly?
Well, thank you very much for having me here on Doctors on Call. I want to explain that the fellowships, which are these letters that you see behind my name, it's not that I'm a jolly good fellow, although I am. It's that these are something you can't ask for. You are actually nominated to receive through the different academies in radiology or radiation oncology, and they are based on your merits through papers that you publish, through protocols that you participate in, through fellowships. And the reason why they're important is that I think a patient needs to be comfortable that who they're dealing with is someone of good reputation, of someone that has distinguished themselves in their specialty, that are board certified. It's very important, and that the where they're actually getting treatment is also certified by these colleges, the American College of Radiation Oncology, for instance. And this makes people, especially since Central Care services primarily the rural America here in Kansas and in Missouri, You know, you don't want to feel like you're going to a secondary type of place because you have no choice. You want to go, I'm coming here because I'm receiving the best that there is. And I want people to feel that.
Absolutely. We already have our first phone call this evening. Let's go to Dodge City, and Kate has a question.
Yes, hello. Thank you. I have a question for the doctor. My husband has been diagnosed with BPH and has been under the treatment care of a urologist for about 5 years. He takes medicine for his BPH. My questions for the doctor tonight are, does this put him, having BPH, put him at a higher risk for prostate cancer? And are there any special symptoms of prostate cancer that we need to watch for? And if it were determined that he did have it at some point, how does the doctor decide if it's a slow-growing or fast-growing cancer? And my last kind of related question is prostate cancer treatments. How do they vary and why do they vary? So I have kind of a multiple question for her.
Well, though all are very excellent questions, and if I don't know how old your husband is. How old is he?
He is now 62.
52. Okay, well, that's very key to the entire story here. BPH, for the people that are not familiar, is benign prostatic hypertrophy, BPH, benign prostatic hypertrophy. And what that is that the prostate normally in men after a certain age just becomes more, it grows normally and it is benign. Now that doesn't mean that there isn't something hidden in there. And where you determine that something is hidden in there is that the PSA or you get this through the blood. You have this test which tests your specific antigen, prostatic specific antigen or PSA, and if it starts becoming higher and higher, you begin to be suspicious that there's more to the story. Now, this I say all the time because it's something that I see commonly a mistake in many of the primary care offices, in that it is very much age related. So many people say, well, you know, my PSA is less than 4, so it is normal. No, the PSA for a man of his age should be 2. So if it becomes higher and higher, you begin to have a suspicious feeling that there is more to the story. Now, there could absolutely be nothing but the normal growth of the prostate. You can have a man with a PSA of 0 and have cancer, and you can have a man with, you know, as I said, a cancer with a PSA of 0 and a man with no cancer and a PSA of 50. But that's rare. Usually it follows the spectrum of, you know, age-related PSA. So what happens if you begin to become outside the norm, then a urologist needs to be involved, and maybe they need to do biopsies. People don't want to be obstructed. Men don't want to be obstructed. They want to be able to have a good flow of urine, and sometimes they have to go through a TURP or transurethral resection where they scrape the prostate. If you can imagine the bladder draining in the middle of the prostate like if it was a donut, they basically take part of that middle and they take it out. And sometimes those chips can lead you to see if the person has cancer or not. Sometimes it takes a sextant biopsy. In other words, they divide the prostate into 6 segments and they biopsy the area so that you are sure that there's nothing. But depending on how malignant, if you have cancer, depending on how malignant the cancer is, and we'll discuss this later, the treatment then is you know, what type of treatment is best for the patient. It is not a smorgasbord. People sometimes feel, I want to do this. But if your risks are high that the cancer is outside the prostate or in the lymph nodes, what you want may not correlate to the situation and maybe something else. Cancer of the prostate, even when it's advanced, can be curable, but you'd have to do the right thing. So for your husband, is being so young, and especially if he does not have a history of cancer of the prostate in the family, and that's key, then following the PSA is important to leading to the right decision.
All right. We do have another phone caller on the line now. Eugene, you have a question for Dr. Perez-Tamayo? Eugene, are you on the line now?
Hello.
Yes, go ahead with your question for Dr. Perez-Tamayo.
Okay, I can barely hear you, but my question is, I've had two types of radiation. Had radiation for the prostate and another type of cancer, and I've been told that I cannot take any more radiation. The cancer did reappear, and they're wanting to do a test with it's kind of radiated tag that they inject you with and then do a scan. Would it be advisable to put more radiation in you?
Okay, that's a very...
And that's my question.
Well, that's a common situation when you have what we call a recurrence. In other words, if there is suspicion that there is a recurrence of the cancer has come back either locally or in the lymph nodes, doing that test, which is a PSMA test or a very specific test that tests where or if there's cancer elsewhere, because the likelihood that you have recurred locally is very low. The likelihood that you have recurred in the lymph nodes or the bones is much higher. So depending on where this recurrence is whether or not more radiation can be given or not. You probably received external radiation and what we call brachytherapy or seeds or needle implants. So if you have received that, or even stereotactic radiation, if you have received that to the prostate, you really cannot receive any more there. And then there's other things to do. So one should first of all look at where you have recurred. And if there is a recurrence in the lymph nodes, for instance, the chances of salvage is good. I can tell you an example. My father, who was a very famous radiation oncologist, had lymph nodes all the way to his diaphragm. And we treated him from the prostate cancer that was very aggressive, and he died of a heart attack 20 years later in his 90s. So if we know where it is, it can be treated. Now, if you've recurred in the prostate itself, now that's a different story. So first find out why your PSA is going up or where you have recurred.
Good questions this evening. We appreciate those. And again, if you have a question, be sure and give us a call. We have a toll-free number, 1-800-337-4788. I thought, Doctor, we might back up just a little bit, some very specific questions for a couple of our phone callers, but maybe let's go back a little bit and talk about prostate cancer in general. I'm curious if there are any physical signs that might indicate a man is or it hasn't been diagnosed yet, but are there any physical signs that he may be leading that way towards a diagnosis of prostate cancer, something that feels different to him?
Well, first of all, the family history is key to this question. If you have had cancer of the breast or cancer of the prostate in the family, especially in a young person, those need to be included in the equation. Then the symptoms would be that you're beginning to have problems with urination, frequency, urgency, just like the first caller that said they'd be following that benign prostatic hypertrophy. Sometimes it isn't benign prostatic hypertrophy, it's actually cancer. So if you begin to have problems like this, urgency, frequency, what you don't want to have is bone pain or back pain, which usually means the cancer has spread beyond the prostate. That would be a much later cancer, which would be a shame. So, if you begin to have these problems, then you need to go to a urologist, and they need to investigate, where you are with this problem. It is something people avoid. Many men, I can tell you, I have gone to fairs where I give free rectal exams and PSAs, and I see the men go around my booth.
They're kind of known for that,
Yeah,
aren't they?
and they do not want to see me. Now, the wives bring them back, but it's something that it's not so bad, and frankly speaking, it could save your life. It is very curable if gotten early.
Good point. So is there an age that regular prostate screening should begin if you don't have a history in your family?
Wait, and that's important because if you have cancer of the prostate in the family, you can start, like at 40 years of age. Or even sooner if you had cancer of the prostate younger. But most men, really 60 and above, is when it becomes an issue. And even 50. It depends on what symptoms you have. But then is when you begin to have the PSAs done. It's very, very inexpensive to get the test. Many of the fairs in Salina have a free fair for prostate, and also fairs in the hospitals, they're free. You can just get a blood test and they can tell you if your PSA, again, it is age specific. So at age 60, if you are 4 or less, you probably don't have cancer of the prostate. However, the wilder the cancer or the more aggressive the cancer, the less it will produce this specific antigen, which is kind of, let's say, a juice in the bloodstream, because it is so wild, it doesn't have the capacity to form this antigen. So you can't trust the blood work alone. A rectal exam is a must. And so when you do a rectal exam, it is complementary to the blood work. And then if the blood work is maybe not high, but at the margin, then you need to have it repeated again, maybe in 3 to 4 months, or maybe in 6 months. And then if it keeps on going up, then there is no doubt that you need biopsies.
I've always heard that prostate cancer is slow growing. Is that correct?
Only if it is a low Gleason score. And let me tell you what that means. Dr. Gleason was a pathologist at Mayo Clinic who devised this method of just by looking at the pathology or the tissue, predicting the capacity of this cancer to grow. So it's like, it's like if you give a tornado a certain, number of how destructive it is. So the higher the Gleason score, and it goes up to 10, and it's a score, which means there's 2 numbers. The first number is the majority of the cancer. The second number is the minority of the cancer. So the pathologist sees a section of the tissue, and it says the majority of the cancer is a Gleason score of 3, and the minority is a Gleason score or a Gleason grade of 3 and a Gleason grade of 3. That would be a Gleason score of 6. That's in the middle. It's neither very aggressive, nor very slow. It's kind of on the slower side. Now, if you have a Gleason score of 8, 9, or 10, your chances of having it in the lymph nodes and going into your bones are very, very high. So it is not slow growing. But 6 or less, it is slow growing. And if you're in the 80s or 90 years of age, the chances that this is going to be a problem for you in your life is going to be very small because it is slow growing. But even for a older man, if the Gleason score is 8, 9, or 10, you're going to have issues, and the issues are going to be very, very impactful on your quality of life. So you don't want to not do something because it will make you regret it.
So listen to your wives.
Exactly. Do not
do it
go
for
around.
yourself. Yes, absolutely.
Yes.
So do you think that are there any things out there on the horizon that might be a better test that we're looking at, or are these kind of the standards?
These are standards. However, once you are diagnosed with cancer, there are new tests which actually can give you, it's called a Decipher test, which can give you your risk of having disease in place, like just in the prostate, or beyond the prostate and having, in fact, the cancer going into your bones or into your lymph nodes. So if you have a aggressive cancer, they're going to test this with a special test that your cancer is going to be put into this decipher test, and you're going to be able to know what your chances are of disseminated disease. And then you can actually have a different path of treatment so that you are going to be cured, or at least you're going to stop this cancer from going into your bones or lymph nodes, etc.
We have another phone caller on the line with us. Linda in Salina, your question for Dr. Perez-Tamayo?
Hello, Dr. Perez-Tamayo. A lot of the doctors in Salina here are saying that we don't really need the digital rectal exam, that the PSA is enough. What's your stand on that?
You know, this is something I have a very hard time hearing, because it's just like when I give talks to women, for instance, I give a talk in Dodge all the time about, I have the women raise their hands about the gynecologists who do a rectal exam along with a pelvic exam. You cannot feel the ovaries or the uterus if you do not do a digital exam with the rectum. So 100% of women do not raise their hand when I say, how many have you had a rectal exam with your pelvic exam? And everyone says no. And I say, run for your life. You have to have a rectal exam, because a PSA will not tell you the entire story. It is a great tool, but actually the best tool is your finger. Now, it is true, because I actually published this, that even when you have urologists do a rectal exam and a PSA, and the radiation oncologists do a rectal exam and a PSA and an MRI and a CT scan, you are wrong 30% of the time.
Oh, gosh.
It's a very high number. So let's not give the opportunity to be 50% wrong. And what is a rectal exam? I think, what are you feeling? And besides, you know, you can have colon cancer, so you can get a kind of a, extra bonus there. But what you're feeling in your prostate, if you can imagine a prostate being a walnut, and let's say the walnut is on its side, the ridge of the walnut is the median raphe, and you need to feel it, that it's still there and it's not flat. And the walnut outline, you need to feel the edges, which means that it's not outside the walnut. So if you cannot feel that, the effacement or the flatness of the shape tells you that there's something wrong. Of course, then you can feel nodules, you can feel hardness, you can feel also fixation. When you do a bimanual exam, which is what I do, you can feel the prostate, it's fixed to your pelvic sidewall, and that's very advanced. So you do need to have a rectal exam, and you should demand it, because not only that, but to test the possibility of rectal cancer.
Let's look on, I guess, the brighter side. How about treatments for prostate cancer? Do we have some success stories?
Highly curable, and in some cases, there is, the possibility of surgery, especially if it's a early cancer, a friendly cancer. And these days, the robotic technique is almost a drive-through. People don't stay in the hospital. In some cases, and depending on the location of the cancer, it is more risky to leave the patient incontinent of urine, meaning that you're going to have a situation where you're going to be drippy, either little drippy or very drippy of your urine. Sometimes the cancer is just not possible to remove with surgery, because it is just a little bit more advanced, or there's lymph nodes. So even then, it's still curable. But you have to treat all the risks. You need to treat the lymph nodes, you need to treat the extraprostatic extension, meaning the fingers. If people know about bindweed, those roots outside, you need to treat them. And you need to treat anything that is at risk, and you are going to be successful. So it's not, as I said, a smorgasbord. And some of these things you may not even see, but you have a risk. If you have a risk, especially if you have a high Gleason score, then you treat these in a preventative manner. So you give treatment that is what we call prophylactic, or we give treatment to the lymph nodes, even though we don't know that they're involved, because the risk is 30 to 40%.
So the good news, again, highly treatable
highly treatable, highly curable.
And get in there early. Okay, so we thank you so much, Dr.
Thank
Perez-Tamayo, for your information. We concentrated on prostate cancer
Yes.
this evening, so we'll have you back another time and talk about breast cancer, but we had some really good phone calls and some really good information coming out for us this evening about that. We want to thank you for joining us this evening, and again, Dr. Perez-Tamayo, and thank her for that. And of course, we will be back next time with Doctors on Call, and we'll be talking about children's mental health. And if you have any questions about that, you can think ahead and email some questions to us for that next program. That email address is doctors@shptv.org. Thank you so much for joining us tonight for Doctors on Call. I'm Becky Kaiser.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from Camco, the state's only Kansas-based medical liability provider, serving medical professionals and advocating for the health for all Kansans.
Russell Regional Hospital. Experts, neighbors, friends.
Your family is our family. Staff at Smith County Memorial Hospital wants to set the standard of excellence for healthcare in north central Kansas.